Good evening, everybody. Thank you all for joining us for the MENASO Cerebrovascular Grand Rounds. We know it's late in the evening in the Arab world, but good evening, good afternoon to wherever you're joining us from. This is the 43rd MENASO Education Academy Cerebrovascular Grand Rounds, and the 7th of this year. And this platform is very, very successful in the region. In this year, since 2024, we've had, I'm told, more than 4,000 participants log in for these webinars. So it's really a big reach, and this is successful because of the very high profile, very high caliber speakers that we have, both locally, nationally, and internationally. So today, as is usual, we have a very interesting sessions lined up for you. The format that we've chosen this year is we usually start with a couple of cases, and then we go on to the talks. So myself and Dr. Arsida will present the cases, and then we'll go on to the talks by Dr. Adnan Qureshi and Dr. Fawaz Al-Mufti. But let me start off by introducing my co-moderator. This is Dr. Sardar Geik. Dr. Sardar is joining us from Istanbul in Turkey. He is a radiologist, and currently he is professor of radiology, diagnostic and interventional neuroradiology. He's the director of the Stroke Center and Neuroendovascular Service and head of the Department of Radiology at Istanbul Aydın University School of Medicine. For those who follow along the neuroendovascular circles, he is the co-director of the iCure Stroke meeting, a very successful meeting hosted in Istanbul. And it's really an honor to have you join us co-moderate this session.
Thank you very much for the nice introduction. When I'm listening, I was thinking, is it me or not? I didn't realize that I have that much. I have that much title, but
he's modest. He's modest.
No, come on. But it's my honor, pleasure to be the part of the Middle East North Africa Stroke Society activity. So, and then we have Fawaz with us, we have Arsida with us, and we have international speakers and two really important topics, which it's one of them is blood pressure management and the other one is the large core stroke. So better than wasting time, we can start with the cases, then I'm sure we're going to have plenty of things to talk or debate on that one.
Wonderful. So I'll get things started if I can just share my screen. Do you all see my screen?
Yes.
All right, wonderful. Okay, so this is a very brief segue into Dr. Adnan Qureshi's talk, where he'll be talking about acute blood pressure management in ICH. This is a case which can get the discussion going. I do not have any relevant disclosures to this talk. So this is a case quite a while back. This is in 2016. When I was in the Cleveland Clinic in Ohio. 60-year-old gentleman, he's African-American, and he is known to have cardiovascular risk factors in terms of hypertension and type 2 diabetes, which were previously known to be uncontrolled. He is non-compliant on medications, and he was not on any medications at the time of this encounter. He developed sudden onset headache, he had blurry vision and left-sided weakness. Presented fairly quickly to the emergency room, and the examination 2 hours after symptom onset. His blood pressure is very elevated, systolic of 220, diastolic 150 millimeter of mercury. He is fully intact from a GCS standpoint, 15 out of 15, but definite neurological deficits in terms of dysarthria, comprehensible but dysarthric. He's got a left-sided facial droop. He's got left hemiparesis, broadly 3 out of 5 in both the uppers and the lowers. And he's got decreased light touch sensation on the left side. Just quick labs, he had normal coags. The renal function was normal, creatinine, GFR. His troponin was negative. He did not complain of anything else systemic like chest pain. ECG did not show any acute ST changes, but did show features suggestive of left ventricular hypertrophy. And the chest X-ray showed a cardiomegaly, no pulmonary edema. This was a non-contrast CT which was performed. And as you can see, it shows this hyperdensity in the right thalamus. And you can see it's extending to the posterior limb of the internal capsule and the putamen, so involving the basal ganglia also. We do CT angiograms. So this was a CT angiogram. Overall, no large vessel occlusion or any hemodynamically significant stenosis. The vessels looked okay. And a delayed phase CT, which I'm not showing here, did not show a spot sign. So this was the images which were present. And so the diagnosis, primary acute ICH, right thalamus basal ganglia. Primary, not so much that, we know a lot about what is primary ICH now. It's a small vessel disease, either, lipohyalinosis, arteriolosclerosis of the penetrating arterioles, or cerebral amyloid angiopathy. So not so much primary in that sense. We do the ICH scoring. The ICH score was 0, and you can see the components, all of this scored 0. So, of course, the concern with acute ICH is hematoma expansion. And we know hematoma expansion is an independent predictor of morbidity, mortality. It causes neurological deterioration, causes death, causes disability. And one of the intervention, of course, is to reduce the blood pressure. So what targets would you choose? Remember, his baseline blood pressure is 220/150. Would you choose to reduce it less than 160? Would you choose a range of 130 to 150? Would you choose less than 120? Or would you choose an approach similar to hypertensive emergencies without an ICH, where you decrease it about 15 to 25% of initial values? I'll just leave these options up. I'm not sure we have an audience response, but consider these options as we go along the talk.
Yeah.
So like I told you, this was a while back. This was in 2016. The INTRACT 2 trial had come out, which said that it was safe to decrease blood pressure up to 140 millimeter of mercury. And it showed a modest improvement in outcomes. So this target was chosen. The patient was started on a nicardipine drip and achieved target blood pressure within 1 to 2 hours. There were fluctuations while this was being achieved, including occasional drops to less than 120 millimeter of mercury. And subsequently, the blood pressure was kept within the range of 120 to 140. As per protocol at that time, we did repeat a CT head at 6 hours, and hematoma expansion was not seen. So clinically and imaging, the patient looked very, very stable. However, 12 hours after admission, the patient had acute deterioration. He was drowsy. He acutely became drowsy, and he had worsened left hemiparesis, but also had new right hemiplegia. His actual right-sided deficit was a lot more than the left. And again, 12 and 24-hour CT scans after symptom onset showed stable hematoma without any expansion. So what is going on over here? This is a day 2 MRI, and this is a diffusion-weighted sequence. And as you can see, you can multiple foci of restricted diffusion, both sides, right and left, but you can see it's worse on the left side. And it seems to follow a watershed pattern, internal border zone watershed, multiple acute infarcts. So the patient developed acute ischemia in the process of lowering his blood pressure. I'll quickly just share a couple of slides, and we can go on to questions now or later. But for this case, of course, after we saw this, the blood pressure targets were relaxed. The patient had a very slow recovery. It took many weeks for him to improve. But we have to remember that hypertensive individuals do have altered cerebral autoregulation. The curves are shifted to the right. So to maintain cerebral perfusion, they have to have higher arterial blood pressures. And therefore, the concern is if you're too aggressive with systolic blood pressure reduction, that may result in cerebral hypoperfusion. So many series have reported rates of diffusion-weighted hits or acute ischemia in the range of 13 to 39% after ICH. And they are a predictor of poor functional outcome at 3 months. But what happens acutely during hospitalization and what is the effect of different systolic blood pressure ranges on acute ischemia is still not very clear. So this was a retrospective study we did in Cleveland, published in the Green Journal in 2018. And basically, there was a protocol change. So before 2015, the blood pressure was kept less than 160. And after that, once the Interact 2 and the 2015 ICH guidelines came, we reduced it to less than 140. And we looked for the presence of acute cerebral ischemia on MRI performed within 2 weeks, plus acute neurological deterioration, which is basically NIH increase of more than 4. And basically what we saw that in the more aggressive blood pressure control of less than 140, acute cerebral ischemia was more frequent, almost double. And the same acute neurological deterioration was also a lot more common in the less than 140 systolic blood pressure group compared to the 160. If you look at the blood pressure, minimum systolic blood pressure less than 120 over 72 hours was associated with cerebral ischemia, but there was no patient whose blood pressure did not drop less than 130 who developed cerebral ischemia. And there are multiple reports, to the last point here, there are multiple reports that these diffusion-weighted imaging hits are, silent, but that was not the case, at least in this series. They were significantly associated in the short term with worse discharge and IH. So this seems to fit with what has happened afterwards with the ATTACH-2 trial, and this is the 2022 guidelines. The sweet spot is 140, and now the recommendation is to maintain it in the range of 130 to 150, and that's reasonable. But remember, this is for mild to moderate ICHs. So those with very large ICHs, those which require surgery or decompression, we still don't know what the ideal blood pressure target is. Also, everything that I mentioned is for people presenting with systolic blood pressure 150 to 220. So patients presenting more than 220, we pretty much follow the same approach, but the data is less for that range. And we know that dropping it less than 130 is potentially harmful. So in the ATTACH-2 trial, which hopefully we can discuss, there was renal impairment, not so much in terms of the primary outcome. The primary outcome was the same in the aggressive versus the standard control, but dropping it in the aggressive blood pressure arm was associated with renal impairment, etc. Another important thing to consider is that we should avoid fluctuations. Too much fluctuations in the blood pressure while achieving your targets is harmful. So avoiding the peaks, avoiding large variability is very important, and trying to get your treatment within 2 hours and reaching your target within 1 hour can be beneficial. So these are the recommendations from the 2022 ICH guidelines, which I quickly threw up, and hopefully we can discuss more. So what about all other scenarios? So for instance, consider a patient like here. A lot of the comorbidities are shared in large artery atherosclerosis. So for instance, this patient with bilateral severe carotid stenosis extracranial who develops an ICH, what is your blood pressure target there? Consider this individual with an ICH who's got a severe right M1 intracranial stenosis. What if this patient was asymptomatic? What if this patient was previously symptomatic? How would that determine your blood pressure targets in somebody presenting with an acute ICH? What with somebody with known severe small vessel ischemic disease, as in this patient where the MRI flare shows severe, periventricular small vessel disease and lacunar infarcts? What are the subtypes of these patients, and what are the blood pressure targets we need to achieve in these patients? We don't know. And there are tools that we can potentially use, but essentially the point I'm trying to make is that all the clinical trials that looked at blood pressure lowering was to limit hematoma expansion, but in translating this into clinical practice, we have to bear in mind that there is a potential to introduce harm. So I'll stop over here, and again we can open it up to discussions. But this was essentially just a segue to get into Dr. Adnan Qureshi's talk on acute ICH and blood pressure goals. Thank you very much for your kind attention.
Thank you for the presentation. That's to me, it's very interesting because I'm not a neurologist. I'm not part of the clinical management, let's say. Then I listen it very carefully because the first reaction, what I'm thinking of, would be lowering the blood pressure in a bleeding case. But what you are saying that be careful, but lowering in a certain limit. But and then is it all same to the whole group of patients? Because there might be different, like you showed. I mean, there might be um, underlying like carotid stenosis cases. Is it all same? I mean, the same protocol applied to the same stuff that if you lower that one, you may have ischemic stroke. Because when you were showing the case, I was thinking of there should be underlying something about that, why a patient should leave stroke, reducing down the blood pressure to the normal levels, let's say.
Yeah, so again, in the case that I showed, the patient actually did not have any large vessel stenosis, but still had all these infarcts. But to your point, the trials did not, select based on carotid stenosis or intracranial, vascular stenosis when they enroll patients with ICH. So again, I think it is reasonable. The guidelines now suggest 130 to 150, but all I wanted to introduce in the discussion is that, just like in ischemic stroke, maybe a cookie cutter approach to one target fitting all is probably not the same, right? The pathophysiology of each patient is going to be different. Cerebral autoregulation, as we know, is very, very patient dependent, especially in these chronically hypertensive patients where their autoregulation is very different from a non-hypertensive patient or in a hypertensive patient that is well controlled. So, of course, these are all not, studied in the trials, but just to be mindful, that ischemia is also, of course, we don't want hematoma expansion, but ischemia is also something that should be kept in mind when we deal with these patients.
So it's very important. I mean, you have hemorrhagic stroke, and then you face with the ischemic stroke in the same patient as well, just with the blood pressure management. It's a little bit scary. By the way, we should ask what Fawaz is thinking about this one. Meanwhile, there are questions from the audience, 8 questions that you can read and then answer while Fawaz is answering. What do you think about
Yeah,
Fawaz?
no, I think, I mean, thank you for the question. I think the point you guys are making is very valid. Um, it highlights the difficulties in developing and designing a trial looking at blood pressure goals for such a multifactorial disease. Where the bleed is, the size of the bleed, if it's in the pons versus in the in a basal ganglia, the outcome could be very different. And a minimal 1 millimeter expansion could change management significantly. So I'm probably less likely to take risk in a patient with a younger patient with a pontine bleed that can expand 1 millimeter and leave the patient devastated versus a much older patient with a basal ganglia bleed. I think Dr. Sabi's point is very well taken regarding cerebral perfusion. As an intensivist, so in addition to neurovascular surgery, I do neurocritical care. And I think it's a very valid point. In some cases, we know if you reach the end of the autoregulation curve, the intracranial pressure starts to become one-on-one. It becomes translated. As the blood pressure goes up, your ICP goes up. And that complicates things significantly. In those cases, quite honestly, I even forget the blood pressure. I focus only on cerebral perfusion pressure. But I can only do this if I have a bolt. I have a pressure, a monitor in the brain telling me what the ICP is. Then I'm actually saying, okay, fine. I know that the ICP is elevated. I'm going to need to essentially perfuse the brain because I have the rest of the brain to salvage as well, right? So I think it's very complicated. I tend to be a little bit more liberal. I try to use a personalized approach. Whenever possible, whenever there is a drop in the patient's Glasgow Coma Scale, I will make sure that my patient has an intracranial monitor to essentially help guide my management, and help me get at least some sort of assessment of what the intracranial pressure is. Generally speaking, I think these trials, and I'm very curious to hear what Adnan's going to say, but these trials are generally very difficult to design because it's very hard to imagine that one intervention, controlling the blood pressure, is going to affect outcome, right? It's such a difficult multifactorial disease. It's very hard to control for all the different variables. It just becomes very, very hard. So at this point, I am doing exactly what you said, Sebi, as far as like blood pressure. I keep the blood pressure between 130 and 150. If their Glasgow Coma Scale is like 13 and above, if they have if they're not following commands or they're confused in any way, I'm putting a bolt and I'm tailoring the blood pressure according to the cerebral perfusion pressure. And I honestly don't know if that's the right way to do it. I have the luxury of being able to do this here because I have like neurosurgical support. We're able to place these bolts, but I understand that it tends to be a labor-intensive process, and not every place is able to do that.
Yeah. I'll answer a few. Go ahead.
I would like to make a quick remark based on our ischemic stroke experience. 2 remarks, in fact. First, we approach to every stroke patient with a neural code. So it means that when the patient is in the emergency unit, he will be directly taken to the CT. So the door to radiology time is very short. So we can lower the blood pressure very, very early in the first appearance of the patient in the stroke. So I think it's very important for this patient to know to lower the blood pressure very, very early in the ascent of the hemorrhagic stroke, because as long as they stay with a high blood pressure, the risk of developing cerebral autoregulation problems is high. And I don't know if you have a subgroup analysis, but in ischemic stroke, patients that have cerebral autoregulation problems tend to have chronic renal failure or diabetes more than the other group of patients. So maybe detecting the group of patients and then managing the patient according to their characteristics should be a better approach to this patient, because sometimes patients come to the emergency unit within 1 hour of onset, but it comes maybe 1 hour for the patient to lower the blood pressure. So it keeps 2 hours with a blood pressure more than 20. So this means that autoregulation can be broken more early. And in terms of risk factors, I don't know if you have a subgroup analysis, but renal failure or other systemic disease can have the tendency to develop this kind of issues more. So maybe analyzing this and putting out which kind of patient tend to have this kind of ischemia is better than doing each patient with a medium blood pressure, because we know that we are saving these patients with lower blood pressure.
I understand correct. Rather than decreasing blood pressure empirically, better than defining the hemorrhagic or ischemic and then manipulate it. Is that what you're saying? Because for the hemorrhagic cases, decreasing the blood pressure is important in the early phase, and then which is vice versa for the others. If you decrease for the ischemic, you may have problem.
Yes, that's why it's important the door to radiology time for each patient, so that you can manage the patient very quickly, because as long as the patient stays with a high blood pressure, the probability of you developing dysregulation should be higher. But I don't think that there is a study that has studied especially the time metrics like in stroke. In ischemic stroke, we know very well the time metrics about the approachment, but in hemorrhagic stroke, we know that we have to lower the blood pressure immediately, but we don't know the time metrics in terms of 30 minutes, 1 hour, or other parameters. So maybe these are points that should be...
That's a good point. Maybe somebody can plan a study on that one.
Yeah, so again, for the purposes of the wider audience, the new guideline is 130 to 150 to achieve the systolic blood pressure target without much fluctuation as early as possible, usually 2 hours, and to achieve your target in 1 hour. This is what the 2022 guidelines is Probably I'll answer some of these. I can type it and go, Sardar, and we can start
No,
with
no,
the
go
next
ahead,
case.
but this may be important. It is why nicardipine, why not labetalol?
So again, we don't know basically both agent and the way we use it. Is it an infusion versus bolus with regards to reducing the blood pressure and outcomes? So whatever you're comfortable with, but probably venodilators may be avoided. What is the significance of having CTA? If it's a primary basal ganglia, that's well taken. If it looks like a primary bleed, we don't necessarily need a CTA, but what we can do is a delayed phase CT, and you can get additional information like spot sign, which can, help you manage your blood pressure. So if there is a spot sign, you probably want to be more aggressive with getting your blood pressure down, because that is a predictor of hematoma expansion. Next question, 140 to 150. Yeah, sweet spot is 140. So if you can target a range of 130 to 150. Next question, definitely to avoid fluctuation with whatever agent you use. Nicardipine is very reasonable. Then there are some questions on AF and antiplatelet, which probably we can get to later.
Okay. So half is answers, half you're going to type.
Well, yeah.
Okay. So we will continue with Arcida's case and then Fawaz's lecture, okay? Arsi.
Okay, so I will present a large core case presentation. I have no disclosure, and for the sake of discussion, I have chosen very short, but two cases, not only one case. So my first case is a case of MR based. It's a case of a patient with 51-year-old pre-awareness 0, which was in our unit within 5 hours of onset, within an age of 24, with a very high NIH. Now you can see the patient diffusion MRI. So in our center, we used to do all the stroke rotation with MRI. So this is a case of a patient with acute onset, but diffusion imaging as a choice imaging. The diffusion shows a very large infraction of the whole MCA territory. You can see that aspect score, it's approximate 2 or 3. And you can also check the flare, which is pretty good for this patient. You can see some involvement of the basal ganglia or maybe insular area or some cortical involvement, but you cannot see a very predominant involvement of the patient in terms of flare. Perfusion deficit shows a very big perfusion deficit in the MCA region. With a very preserved CBV in most of the territory, especially in the cortical area. You can see that the CBV of this patient is well preserved together with the diffusion. So this is a patient with an age 21, diffusion aspect score 2 to 3, with a very good timing, 300 minutes into the door. So would you treat this patient or would you go conservative because of the high aspect? The question that raised here are two most important questions. One, we have a diffusion aspect score, which know that it can be changeable. So CT aspect of this patient, we don't know. It can be different. And cortical involvement of this patient is different in terms of areas. So is eloquency important? I will speak about this question during the presentation. So we treated this patient. It had an M1 occlusion, and it's treated within 14 minutes from the femoral puncture, which is a very good and fast treatment in terms of recanalization. 24-hour CT, you can see that most of the area is infracted, but still with edema. This patient didn't need a decompressive craniectomy. We managed it only with medication. And you can see patient's CT 72 hours later. And you can see that the cortical area, especially here, is well preserved, while the basal ganglia, the insular, and the temporal area of the patient is in ischemia right now. Then if we followed out the patient, the discharge age was 14. Within 10 days, he was discharged to a rehabilitation center, but he managed to have an MRS of 2. Why? Because if we see again the CT, you can notice that this patient motor area, cortical area, is preserved, as you can see here. So only this small cortical area helped this patient have the motor points less than when he was in the onset. So this patient is able to, because we know MRS is related mostly to the ability to be able to walk. So this patient was able to walk and be independent with help within 3 months. So the second patient is a patient with a CT-based imaging. You can see that it's the same age, 62 years old patient with pre-MRS of 0, with an age of 24, and within 3.5 hours of onset in our door. So patients within the good timing. So CT of this patient shows, as you can see here, a large involvement of all the MCA territory, involving also the cortical area, the deep ganglion area, the insular area. So aspect 3, it may be higher, maybe aspect 2 can also happen for this patient. When we analyze the CTP of this patient, you can see that it only has a CBV lowering in the temporal area. The other areas of the patients are more well preserved. So you think that with this patient with a high, very low aspect, you are waiting for an M1 occlusion. Hypodensity grade on CT is very high. Partial CBV changes, do they impact prognosis? We can see. So do you take this patient directly to endovascular treatment despite the low aspect, or would you go conservative for the sake of large core? We treated this patient. So you can see that perfusion is very important. As you can see here, the patient has only an M2 occlusion. Maybe he had M1, which migrated to M2, we don't know. But the patient has an M2 occlusion, which was treated with the TK3 within 25 minutes. So how did this patient do? Let's check. CT within 24 hours shows a hemorrhagic transformation, especially in the parts area of the lower CBV, with a very big edema in the left MCA territory. And as you can see, he was intubated and he needed a compressive craniectomy within 24 hours, which helped the patient. But still, even after the decompressive craniectomy, patient's CT in the first week is, as you can see here, it's a large damage, mostly involving the cortical area, as you see. And the patient MRS within 3 months, it's 4. So for this patient, what came up as a question is onset imaging pattern relationship to prognosis. So the difference of this patient with the other patient, if you see in terms of radiologic imaging, is only the motor cortex area, which is preserved. And in terms of large core, our best expectation is for MRS 4, or can we do lower in this kind of patient? Can MRS be lower when you have that kind of CD? That kind of CT, and age, of course, is this compromising factor. So these questions partially were answered by the trials. This is the table involving the trials, including large core. And partially, age is an important factors, is CT aspects and diffusion aspects are different. These trials help us answer most questions about large core. That's why we need to treat patients with large core right now. But what we would like to discuss today with the panel, and what I think everyone has in their own practice, it's, for example, CT aspect, the inter-evaluation change. As you can see, I had 2 CTs, and hypodensity change between CTs. Sometimes is it too hypodense? Is it no? Is it less hypodense? Is something that is eye inspection, so it can change. Second, imaging modality differences have a huge impact doing the patients with diffusion. As we know, TESTA, Rescue Japan, Select, and Angel primarily took patients with diffusion, but only last intention had most of the patients with CT. And we know that CT aspect, it's more prone to ischemia. So CT aspect has a more large core impact in terms of imaging. Early versus late window patients, they change. Early window patients, I think that they all should be treated because we don't know that early we still can have salvageable tissue. And to my opinion and to our approachment, two main points that are not discussed until now are the post-thrombectomy follow-up, because as we know, we are living in a region which has very different, hospitals are very different, and we know that when we do a patient which doesn't have a very good outcome after thrombectomy, he's managed in the stroke center plus rehabilitation is very important. So in a very good stroke care with a very good rehabilitation, you can have your patient has the MRS score shift from 6 to 4 or 3 maybe. But in a place that you don't have a chain of organization, you can have a large core patient done very well with a TK3, with a very good imaging, but after 1 week, you have to have a team which can follow up the patient and can rehabilitate the patient. So these are parameters which I would like to discuss with you. And I think that right now we don't have the perfect answers according to the randomized control studies that we have. Thank you.
Wonderful.
What do you think, Sabi? If you agree, let's go with Fawaz's talk and then wrap up and discuss afterwards. Or
I think so. I think we should do it together. I just want to make sure Dr. Adnan's availability. Dr. Qureshi,
Yes.
would you be able to wait till Fawaz is finished, or?
I have to be back.
Okay.
I feel there's an active procedure going on. I'm sorry.
No worries. No, that's perfectly fine by me. Whatever works.
So, no problem. So we'll stick to the schedule, Sardar. It's again an honor to have Dr. Adnan Qureshi join us. He's very well known to the region, very well known to the MENASO Society. And, he is a pioneer in cerebrovascular, especially intimately involved with ICH and a lot of the blood pressure trials. So we are very fortunate to have him. And he's going to talk to us about blood pressure management in acute ICH. Dr. Qureshi, the floor is yours.
First of all, thank you so much for inviting me. So I'm actually going to be talking about the quality and effective of blood pressure treatment in acute stroke. Just a minute. So, as John was mentioning earlier, that we do have the guidelines. So we have the American Heart Association, American Stroke Association guidelines for intracerebral hemorrhage that actually were just released in 2022. And the guidelines that kind of acknowledge that, blood pressure reduction in patients with intracerebral hemorrhage is of value and may actually improve functional outcomes. And it's also putting a time target. So essentially, the treatment should be initiated as soon as possible, preferably within the first 2 hours after intracerebral hemorrhage. And the treatment goal should be achieved in the 1 hour after starting treatment, and with the real goal being to prevent hematoma expansion and subsequently improving outcome. Now, patients who actually are candidate for blood pressure reduction are those who actually have an initial systolic blood pressure between 150 to 220 millimeter of mercury. So the guidelines does not cover anybody with a blood pressure that's more than 220 millimeter of mercury, because we don't really have enough data about that. It really just applies to patients within 150 to 220 millimeter of mercury. And it essentially says that the target should be around 140 millimeter of mercury. So the important thing to know is the systolic blood pressure is the target. And the guidelines actually say blood pressure should be reduced in the selected group of patients to around 140 millimeter of mercury. And as John was saying, that probably ends up translating between 130 to 150 millimeter of mercury. Now, in the guidelines, there's something new. So, the guidelines always had the blood pressure targets, had the evidence level, the level of evidence. But the first time the guideline put something new there, which is continuous, smooth, and sustained control, avoiding peaks and variability in systolic blood pressure. And this was actually something new, kind of acknowledging that blood pressure fluctuation independent of blood pressure reduction, actually can impact outcome. And the outcome should be, or the blood pressure reduction should take into account that we're going to avoid blood pressure fluctuations, and the reduction would be smooth and sustained. Similarly, in the ischemic stroke, the guidelines have been very similar, all the way from when intravenous thrombolysis was introduced. So essentially, maintaining systolic blood pressure less than 185 millimeter of mercury, diastolic blood pressure less than 110 millimeter of mercury before giving intravenous thrombolytic therapy. And the same guidelines were actually applied to mechanical thrombectomy. So the same guidelines were simply extrapolated to mechanical thrombectomy. And again, keeping the systolic blood pressure less than 185 millimeter of mercury. Now, even the ischemic stroke guidelines now are acknowledging the value of blood pressure variability and avoiding blood pressure variability. Now, there's a little perspective on the history of blood pressure. And many of you may recall the first time somebody measured blood pressure was in 1733, where they cannulated the common carotid artery of a horse and actually measured the value. And they made two observations. One was obviously the absolute value of blood pressure, but they also noted there was considerable variation in blood pressure as the monitoring continued. Now, as the history goes the next 200 years, the concept about variability was lost, and only the absolute value of the blood pressure is what actually ended up staying and becoming a therapeutic target. And you can see there's considerable increase in the interest in blood pressure treatment as we go through the recent years, and the number of publications continue to increase. So just kind of highlighting that how blood pressure treatment has become an integral part of not just secondary stroke prevention, but actually a part of all acute neurological emergencies and actually non-neurological. Now, one of the challenges obviously is that we've always considered blood pressure as a static variable, a single record. But blood pressure is not a static variable, it's a dynamic variable. Essentially, we think that it's like a single snapshot. But blood pressure is more like a video recorder, where everything is changing minute to minute. And when we don't consider that particular aspect of this measure, we may be missing valuable information. So that's actually what, now our understanding is that at least in stroke and intracerebral hemorrhage, blood pressure should be considered a dynamic variable, not a static variable. And again, it just goes down to, as I mentioned, even in 1733, when Hayes actually first measured the blood pressure, he also noticed the dynamic nature of the blood pressure. And now that, we're over 200 years now we're actually going back and recognizing what something had been observed in 1733. Now, the guidelines, if you would notice, are focused on systolic blood pressure. And there is reasons for that. Systolic blood pressure actually is more sensitive than diastolic blood pressure in identifying fluctuations and variability in patients with both ischemic stroke and intracerebral hemorrhage. The relationship between hematoma expansion and even death or disability in intracerebral hemorrhage patient is really seen with systolic blood pressure, not with diastolic blood pressure, not with mean arterial pressure. And similarly, the post-thrombolytic intracerebral hemorrhage, the relationship again is seen with systolic blood pressure in patients receiving intravenous thrombolysis. The mean arterial pressure is more a reflection of diastolic blood pressure. So it does really underestimate the dynamic nature of systolic blood pressure in the first 24 hours. And now most recent trials have used systolic blood pressure as the therapeutic target when they're actually evaluating intravenous antihypertensive treatment in patients with or even without stroke. Now, the issue is that when we talk about autoregulation, because one would actually argue, what does the blood pressure fluctuation mean? Because the cerebral blood flow should remain constant. But autoregulation essentially is two kinds of autoregulation. We've always focused on the static autoregulation, which means that blood pressure is gradually reduced. The cerebral blood flow will remain constant to a certain limit. But there is actually another form of autoregulation called dynamic autoregulation. That autoregulation is responsible for maintaining constant cerebral blood flow when the blood pressure change is very dramatic and very quick. And interestingly, yes, the patients who actually have a stroke, the static autoregulation is preserved. So if you reduce blood pressure gradually, you should have no changes in cerebral blood flow. But the dynamic autoregulation is what is impaired in stroke or the post-stroke period. So blood pressure changes, rapid blood pressure changes will actually result in a consequent change in regional cerebral blood. Now, clinical trials that have looked at the effectiveness of blood pressure treatment, such as the antihypertensive treatment of acute cerebral hemorrhage or ATAC2, essentially, at that time when these trials were designed, the real goal was to reduce blood pressure. So the trials were actually taking patients who come with a systolic blood pressure more than 180 millimeter of mercury and really randomizing them to standard treatment, which was the goal of 140 to 179 millimeter of mercury, or the intensive treatment, which was the goal was between 110 to 139 millimeter of mercury. And the goal was that intensive treatment would reduce the rate of hematoma expansion and subsequently reduce the rate of death or disability that is a result of hematoma expansion. And if you look at what we look, this is the blood pressure recordings for the first 24 hours in ATAC2. And you can actually see the standard treatment group and the intensive treatment group actually differ. Oh, excuse me. Yeah. Okay, maybe this looks better. So the standard treatment group and the intensive treatment group, the groups start differing very quickly. And you can see there's a considerable difference even in the first 2 hours between the standard treatment group and the intensive treatment group. But these recordings, are they really telling the complete story? One is actually the effectiveness of blood pressure control. So, the guidelines today are kind of a reflective of what ATAC2 actually used as the primary endpoint. The ability to reduce target systolic blood pressure within 2 hours of randomization. And obviously there was a difference. So the intensive treatment group, there was a harder time achieving that goal. So 12.2% of the patients did not meet that endpoint. And then secondly, for the next 24 hours, if the hourly minimum blood pressure exceeded the upper limit of the defined target, then it was a secondary treatment failure. And again, in the intensive treatment group, 15.6% of the patients actually had secondary treatment failure. So nonetheless, when you try to achieve intensive systolic blood pressure reduction, you can expect a certain amount of treatment failures because it's just not as simple to reduce blood pressure to aggressive thresholds. And, even as early as 2011, we had actually proposed that time to achieve target should actually be a matrix, not just actually specifying that you reduce blood pressure, but not putting a time parameter would actually take away from the effectiveness of blood pressure reduction. So at that time, we've said that the systolic blood pressure should be reduced within 2.5 hours of the detection of elevated blood pressure. And actual lowering and not the treatment goal specified is essential. So once you specify reduced blood pressure, you have to monitor to make sure you actually achieve the blood pressure if you really want to achieve the benefit of blood pressure reduction. Now, I just want to kind of elaborate on the blood pressure. Now, we always focus on systolic blood pressure value, but I also want to highlight that this is a first order variable. And you can simply use the systolic blood pressure at baseline. You can use the systolic blood pressure at defined time points like 2 hours, 6 hours, 24 hours. But this is really the first order variable. The second order variable requires a certain level of computation, more than you can pick up on the monitor. So you have to look at the absolute change. So you look at the change between the initial blood pressure and the blood pressure at a predefined period, whether it's 6 hours, 12 hours, 24 hours. You could also actually take a mean or median value over a defined time period. But second order variables require a certain computation. The third order variables require the highest level of computation. And that actually requires modeling. So you actually have to define like regression plots that best reflect blood pressure change over a certain period of time. And again, when we talk about systolic blood pressure target, there are the first order variables that are just absolute systolic blood pressure values. Second order variable, a percentage systolic blood pressure reduction. And a third order variable will be the actual time to reach blood pressure. So now you're taking the change in blood pressure and you're taking the time to create a single variable, time to reach systolic blood pressure. So the variables can increase in the complexity. So I really want to highlight this point that blood pressure recording has multiple layers of complexity. Now, we all know that you can reduce blood pressure, but it may not stay in the threshold for the next 24 hours. So you can simply count the number of times it's actually above or below the threshold. That would be a first order variable. The second order variable will be the proportion of time, the proportion of recordings that are above or below the threshold. And the third order variable will require computation, which is something like an area under the curve or percentage time in the therapeutic value. And similarly, you have systolic blood pressure variation fluctuation. The range is the simplest variable. Then you have standard deviation of the mean value, or you can actually have proportion of recording that actually exceed 2 standard deviations. That would be a second order variable. And then you go to the most complex variables like coefficient of variation, successive variation, average real variability, residual standard deviation. So now actually, as you go into the third order variables, you get the most prognostic value for any of these parameters: systolic blood pressure value and target, systolic blood pressure fluctuation. When you do the third order variable, you will have the most prognostic value. But then there is a practicality. You cannot be calculating the coefficient of variation while you're actually increasing the dose of intravenous antihypertensive medication. It's just not practical. So when we go from first order variable to third order variable, the value keeps increasing. The prognostic value of systolic blood pressure keeps increasing, but the practicality keeps decreasing. So obviously, second and third order variables cannot be used in real time to actually monitor and modify treatment. And I think that's where the next step is: artificial intelligence. Using the artificial intelligence to do the work, do the computation in real time, so you can actually take the maximum amount of benefit with this systolic blood pressure recordings. Now, I also want to highlight that systolic blood pressure value is a multi-tier derivative. Obviously, it's the baseline systolic blood pressure. It is affected by the intravenous antihypertensive medication. There can be spontaneous decline in systolic blood pressure, which may not have the same value as the response or reduction second to intravenous medication change. Intravenous sedatives and hypnotics also affect systolic blood pressure variables. Intracranial dynamics also have a bidirectional component. The systolic blood pressure increase may be a consequence of intracranial dynamic changes. And again, renal function. So again, as you start to decipher systolic blood pressure, it's important to know you're talking about a multifactorial derivative of multiple components that are actually happening simultaneously in patients with intracerebral hemorrhage or even ischemic stroke. Now, essentially, the new trial, the clofazimine for antihypertensive treatment of acute intracerebral hemorrhage, the CLUTCH trial, which is the multinational trial, and actually, is actually run or planned to be run in 4 countries at this stage. And it's an interesting trial that wanted to actually look at systolic blood pressure reduction, but it also wanted to incorporate the new guidelines and wanted to add systolic blood pressure reduction with stability within 60 minutes of enrollment. And the primary hypothesis is that the rate of achieving systolic blood pressure reduction with stability will be 7.5% or greater in patients who were actually treated with intravenous clobetapine as compared to those who were treated with alternate intravenous antihypertensive regimen, which in the United States, for the most part, is going to be nicardipine. And essentially, this whole target was defined based on the guidelines of the American Heart Association, that yes, we want to reduce blood pressure between 150 to 130 millimeter of mercury, but we want to make sure the blood pressure stays there. So for the next two recordings, if the next two recordings taken 15 minutes apart, the blood pressure will still be between 130 to 160 millimeter, 130 to 150 millimeter of mercury. And then all of this should be achieved within 60 minutes of initiating treatment, consistent with the American Heart Association, American Stroke Accident Guidelines. So then it actually becomes more complex. How do you define it? So for example, in scenario 1, the systolic blood pressure will reduce to less than 150, more than 130 millimeter mercury, but the next two recordings actually were still in the therapeutic range. So then it is a therapeutic success. In another scenario, blood pressure will reduce to less than 150 and less than 150, more than 130 millimeter mercury, but the next recording is actually more than 150 millimeter or less than 130 millimeter. So that is not a therapeutic success. That is not a therapeutic success. You achieve blood pressure, but you do not achieve blood pressure reduction with stability. So you have to wait till you can actually get back in range and actually maintain stability. Only then you have achieved the therapeutic goal specified by the trial. So I just wanted to actually mention, some of the new data and how that data has been incorporated into clinical trials and perhaps clinical management. But I always want to show this particular slide. Blood pressure treatment is part of a multifaceted treatment in patients with intracerebral hemorrhage or ischemic stroke. There were several components that have to work together to maximize the blood pressure, maximize the benefit of blood pressure treatment in intracerebral hemorrhage and ischemic stroke. So I actually want to conclude here, the complex and dynamic interplay of variables related to quality and effective blood pressure control perhaps actually require integration of artificial intelligence in our neurointensive care units. The choice and dosing of pharmacology agents has to be very dynamic to optimize blood pressure control for stroke patients in our neurocritical care units. Thank you.
Wonderful. Thank you, Dr. Qureshi. Thank you for that detailed talk and taking us through a lot of acute ICH blood pressure management. And like Fawaz was alluding to earlier, it's quite a complex issue, and dichotomizing things to above or below, one value does not, of course, answer the whole story. If you have time, we would love for you to stay with us, but I understand you're busy. So thank you very much for your time and participating for the MENASO. We really appreciate it.
Thank you so much for inviting me. I hate to meet Fawaz's talk. His talks are always excellent, but I'll pick up the recording. Thank you so much for having me.
Thank you very much.
So much. Thanks, Adnan.
So we're slightly behind schedule, and I want to give the large core topic enough time for discussion from both Dr. Fawaz and Dr. Arsida. So without further ado, Dr. Fawaz Al-Mufti, very, very honored to have you join our webinar, and we are very excited to hear your talk about large core. As he alluded to earlier, he's triple trained. He's a neurologist, he's a neurointensivist, and a neuroendovascular surgeon at Westchester. Very, very, again, intimately involved in the endovascular societies in the States, and we are happy to have him participate in the Middle East also. Thank you very much, Fawaz.
All right. Thank you so much. Thank you for the kind introduction.
Before beginning, I want to ask, what is that triple trained?
So I'm triple board certified, neurology, neurocritical care, and neuroendovasculars. I think, like you, I was shocked. I was like, is he talking about me?
Oh, no, come on. How did you manage that much neuro? I mean, you need to be so patient for them. I mean, isn't that all the neurology is enough?
Exactly.
I think Arsida will have a talk with you tonight.
I know. I guess so.
Fawaz, you're on presenter mode.
Oh, I am. Okay. Wait, let me just switch that. swab. How does it look now?
Excellent.
Fantastic. All right. Well, thank you so very much, everyone, for having me. I'm truly honored to be here. We're going to talk a little bit about large core strokes. And I think that what Dr. Osita highlighted beautiful points, fantastic points that I'm going to try to cover to the best of my ability over the course of this talk, but I'm really looking forward to the talk at the end. I must say, I was hoping, I mean, I love listening to Adnan talk, but I was like, maybe I can take his time slot and give speak more about this, but I'll try to go through this as soon as possible, as fast as possible. These are my disclosures. I truly have nothing relevant to disclose. I always say I don't feel like I have any conflicts. My wife, however, is very conflicted with how hard I work. So she has a lot of conflicts with this. I also have one conflict is if I have a large core stroke, I would like to undergo thrombectomy. That's my conflict of interest. So hopefully I'll be able to convince you guys that this is the way forward, and don't take my word for it. You have 6 trials to prove this. So this is basically the outline of what we're going to cover today. So where did we stand before the large core trials? So we have a decade of stroke research, basically almost from 2015 until today. Endovascular thrombectomy was proven as standard of care for large vessel occlusions with an aspect score more than 6. But at some point over this decade, we had to pivot. We went from a time-based diagnosis to a time-based trigger to intervention to essentially a tissue-based threshold for intervention. We said it doesn't really matter if you're within 4 hours or 6 hours or 24 hours. We're going to take you, provided your tissue is salvageable. This is one of Kobe Bryant's brilliant game back in 2009. Again, the king of pivoting. So patients with acute were basically found to have large ischemic strokes and or low aspect scores were largely underrepresented in these trials. The rationale for excluding these patients was based on perceived futility. We just think these patients are not going to do well. Their deficits are beyond reasonable functional salvage. Concern for reperfusion injury. If I open up this blood vessel, I'm going to cause harm because there's going to be global cerebral edema and subsequent bleeding into a large infarcted area post-EVT. And the question is, why did we, this was our belief, why did we have to change it? Why did we need these large core trials? So large core trials, large vessel occlusion strokes account for between 15 and 20% of all large vessel occlusion from stroke patients. Mediation analysis have shown that a small proportion of endovascular thrombectomy patients' benefit is explained by reduction in infarct volume. And reperfusion in aspects between 0 and 5 patients have been shown to reduce edema formation and the incidence of malignant infarction. Hence, there was a need to design and conduct randomized controlled trials specifically for those patients. You can see over here, this was a Hermes meta-analysis, and basically it divided patients between standard of care versus endovascular thrombectomy and patients who had a low core and a larger core. And you can see that regardless whether they underwent endovascular thrombectomy or best medical management, these lines never interacted. So there was definitely clearly a benefit. However, when you actually look at a forest plot, in the patients with an aspect score of 0 to 5, we didn't really find a huge benefit, primarily because, or at least the confidence intervals were pretty large because the numbers were very small. Only 121 patients were included here, and it crossed 0. And this is why you have a very wide confidence interval. So the key question was, so we have to solve this problem. The key question was, does endovascular thrombectomy or intra-arterial therapy improve outcomes in patients with large core strokes, aspects of 0 to 5? Is there an infarct size threshold predictive of futile treatment or reperfusion? And what is the safety in this patient population? To answer the things that basically prevented us from offering this in the first place. So we're going to talk a little bit about these trials. So how do you overcome the risk of reperfusion injury in large ischemic stroke? So what if we thought for a second that the concept of ischemic score is not necessarily the one like the ultimate deciding factor in whether a patient is going to do well or not. So how did we come up with the perspective of an ischemic core? So in the 1950s, there was some research that showed neurological function deteriorates when the cerebral blood flow fell below a certain threshold. In the 1960s, there was further research that showed hemiparesis occurred when the cortical cerebral blood flow dropped less than 30% of their baseline, which is now commonly used as the threshold to distinguish ischemic core from penumbra. In some primate studies, it revealed that the time-dependent cerebral blood flow threshold for irreversible damage, permanent occlusion had a lower CBF, accurately identified infarcted tissue, and with short-term occlusion, even very low CBF did not always progress to infarction. And that's basically how we came up with our current concept, at least until recently. And that we also learned that gray matter is more vulnerable to ischemia than white matter. Ischemic core volume is now widely used as a selection criteria for treatment, and the underlying assumption is that the large core volumes indicate less salvageable brain tissue, and the patients with such large core strokes are less likely to benefit from endovascular thrombectomy. Now, if we dig deeper into our understanding of the core, tissue variability is time dependent. So even when you have low CBF, 5 to 15 mLs per 100 grams per minute, this can potentially recover if the flow is restored quickly, since the rate of penumbral consumption is variable and multifactorial. Also, there are certain limitations of current practice, imaging practices. Accurate prediction requires repeated measurements over time, which is something we don't do. We measure imaging once and we don't repeat it usually. The recent clinical practice allowed only one-time assessment of the core volume before deciding on endovascular thrombectomy. And there needs to be a deeper understanding of our ischemic core on early imaging. It's not actually infarcted tissue. In fact, it is a probabilistic estimate of tissue likely to become infarct without fast reperfusion. So that's basically what this is actually telling you. So with the new understanding of core comes new challenges. A one-time measurement cannot definitively determine if the tissue is already infarcted or potentially salvageable. In other words, we lack the ability to distinguish between pan-necrosis and incomplete infarction. And there is no clinically available gold standard for ischemic core on imaging. So it became necessary to give large core patients a chance, and we didn't give them only one chance, not 3 chances. We gave them 6 chances. So let's just shift gears a little bit and start talking about the large core trials, which Dr. Arcida started to discuss very, very eloquently. And I'm going to try to go through these as quickly as possible. As you can see, these are the 6 large core trials: Tension, LAST, Tesla, Rescue Japan, Select 2, and Angel Aspect, not in the order in which they were presented and the results were presented. They varied. There were definitely variations between these trials, whether they primarily used non-contrast CT head, CT perfusion, or an MRI, for example. Lastly, for example, almost 50% of the patients underwent MRI, which is, again, not necessarily easily available in most centers. The NIH stroke scale also varied significantly. Tension primarily had an upper threshold of 26. Last day had more than 5. Tesla was more than 6. Rescue Japan was more than 6. Select 2, and almost everything else was more than 6, but less than 30 in Angel Aspect. The vast majority of these trials looked at patients who were less than 24 hours. And again, they varied significantly. So with regards to Rescue Japan, again, they basically looked at a total 203 patients. They looked at an ordinal shift in modified Rankin scores and an improvement in more than 8 points in NIH stroke scale at 48 hours. Apologies. So basically what they found was, with regards to the primary outcome, an MRS of 0 to 3, endovascular thrombectomy group had almost 31% favorable outcome with an MRS of 0 to 3 versus 12.7%. And just in the interest of time, I'm going to like skip through the detailed discussion of each one of these trials because I'm sure all of you are familiar with a lot of this data, and I'll try to go to the summarizing slides in the near the end of my talk. Select 2 by a good friend of mine, Amr Siraj, was published, and basically their main safe basically what they found was of the 352 patients, 178 in the endovascular thrombectomy arm, 172 in the medical care arm. The generalized odds ratio for a shift in the distribution of modified Rankin score towards a better outcome in favor of endovascular thrombectomy was 1.5. Basically 20% in the endovascular thrombectomy arm versus 7% in the medical best medical management arm, with independent ambulation occurring in almost 37.9% versus 18.7%. And early neurologic improvement occurring in a significantly lower than we'd expect with the large core trials, 11% versus 7.6%. With regard to safety, there was symptomatic intracranial hemorrhages was 0.6 versus 1.1. And mortality, so there was no significant difference between the two groups. With regards to mortality, again, there was no difference in mortality in the two groups, 38.4 versus 41%. And neurological worsening, again, there was 24% in the endovascular thrombectomy arm versus 15% in the medical care group. With regards to angel aspects, here, again, they looked at almost 456 patients, and they also found an odds ratio favoring endovascular thrombectomy of 1.3. An MRS of 2 was achieved in 30% in the endovascular thrombectomy arm versus 11% in the medical arm, and 0 to 3 was 47 versus 33% in the medical group. Endovascular thrombectomy was deemed to be, had a 6% versus 2.7%. But as you can see over here, it was not statistically significant. It crossed 0. And with regards to mortality, there was a 21% versus 20% mortality, again, not significant. With regards to endovascular thrombectomy and intracranial hemorrhage, 49% in the endovascular thrombectomy group versus 17% had some degree of intracranial hemorrhage. This was not necessarily symptomatic intracranial hemorrhage. Also, interestingly, here they looked at endovascular, like a decompressive hemicraniectomy. There was a 7% versus 3.6% in the medical care group, and this was not statistically significant, which I thought was very interesting that in Dr. Ursida's case presentation, it showed one case that ultimately didn't need it. Again, not every large core stroke reads the textbook, so it can definitely happen, but it wasn't really associated with a lower likelihood of needing decompressive hemicraniectomy. So we have more trials. Tesla, although not published yet by Dr. Sam Zaidat and Albert Yu, basically looked at here. So basically 300 patients, 152 in endovascular thrombectomy arm, and just under 148 in the medical arm. The primary outcome, here they did a slightly different statistical analysis. The estimation of the treatment effect for shift in distribution in MRS towards a better outcome did not favor any group initially in the 90-day outcome, but I'll show you guys in a second. So this was the 90-day outcome. And based on this, here, the primary trial efficacy endpoint, this table basically shows that the mean MRS, the weighted MRS in the endovascular thrombectomy group, like at 2.9, is higher than the medical control arm at 2.27 with a treatment effect benefit of 0.626. However, as we discussed earlier, they pre-specified the probability that thrombectomy will be superior with respect to improving the weighted MRS than the medical control arm at more than 0.975. But the actual trial, endovascular thrombectomy superiority probability at the completion of the enrollment and the final analysis is shown in the right lower corner, basically falling just short of exceeding the superiority margin for superiority and declaring efficacy. And basically what you see here is like at the 1 year, however, they did find a difference. So the mean weight difference in utility weighted MRS at 1 year was 1.175 in favor of endovascular thrombectomy, with a 95% credible interval of 0.4 to 1.97, all greater than 0, with a Bayesian posterior probability of superiority of 0.99. This is analogous to a one-sided p-value of 0.001. So quite honestly, when I had a long discussion with Dr. Zaydat specifically about this. It was a little bit confusing to us because we always think of p-values, not the Bayesian probability of superiority. So it was a little bit different. They went back and basically came back and said, because at least my brain is programmed to understand a p-value, the p-value for Tesla was 0.001. Likelihood that this is all due to chance, basically. And in the intention to treat at the 1 year outcome, we see that there's a strong signal of benefit exceeding 1 year ordinal modified ranking score with a one-sided p-value of 0.005, dichotomized into like an MRS of 0 to 2 versus that showed an absolute difference of 16.8%. Versus and a one-sided p-value of less than 0.001. Similarly, if you look at 0 to 3, this was a 17% and a one-sided p-value of 0.001. So in Tesla, the 1 year outcome and conclusion, basically the 1 year outcome to further support the original signal of benefit basically showed that the functional independence, an MRS of 0 to 2, was 22%, which is basically 1 in 5 patients benefited from endovascular thrombectomy, and versus in the control, which was essentially 1 in 17. So one potential explanation, and I think Dr. Arcida alluded to this a little bit, which is how long do you need rehabilitation for? So one potential explanation for this greater benefit seen in 1 year versus 90 days is the continued recovery beyond 90 days in large core infarcted patients. Long-term follow-up may be needed for this population with a larger infarct size at presentation. I mean, quite honestly, at least, and again, I realize this becomes the strokenomics kick in, and it becomes very, very hard for families and insurance companies to continue to cover the rehabilitation beyond the first 3 months. But we know that in 3 months, these are sicker patients. The likelihood of us identifying a patient who has this Lazarus effect, where they will miraculously get better like they do with like a low core stroke, and they start walking or they start talking right away, is very, very low. I think in one of my later slides, I showed it's around 1%, between 1 and 2%. Very, very low, unlike the smaller core strokes. But in the case that Dr. Arcida showed, and again, we can discuss this afterwards as well, where we showed the patient did not necessarily get better at 3 months. Perhaps they need a little bit more time. Again, these trials are designed to look at long-term outcome. Well, only time will tell. We discussed this tension. Again, they looked at this 253 patients. Primary outcome was endovascular thrombectomy. Basically, they found that EVT was associated with a shift in the distribution of scores in the MRS towards a better outcome with an odds ratio of 2.5. Just in the interest of time, I'm going to shift to last day, which was, again, an international multi-center prospective open label randomized controlled trial. They basically looked at this similar primary and secondary outcome. Last day is not officially published, but we were able to obtain these trials from Tudor Joven. MRS of 0 to 2 at 90 days was 13% in the endovascular thrombectomy arm versus 8% and in the best medical therapy arm. In the symptomatic ICH, 36.1 versus 55% in the best medical therapy arm, and mortality was 9.6 versus 5.7%. I apologize. Actually, last day I think should be published now. So just to summarize some of these results, between Rescue Japan, Angel aspect, select, Tesla, attention, and LASTE, you can see that the large core trial distribution, like aspect distribution, was significantly higher. You can see that LASTE had almost 50% had an aspect score of 0 to 2, which is, again, very impressive. For good functional outcome of MRS of 0 to 2 in large core infarction randomized controlled trials. The large core trials at 3 months, basically, you can see there is a very clear improvement in outcomes in an MRS of 0 to 2 if you compare endovascular thrombectomy versus best medical management across all 6 trials. There was an increase in mortality in some of these trials in best medical therapy over mechanical thrombectomy. But again, in some of these trials, it was not significant. MRS of 0, like having an MRS of 0 to 2 and mortality in the 4 large core ischemic trials, you can see over here, again, there is a significant benefit and hopefully a slightly reduced mortality in these patients. Okay. Now, do we need more evidence? Myself and my group, we conducted a meta-analysis of the 6 randomized controlled trials. What we found was there was an improved functional independence with endovascular thrombectomy. There was a non-significant decrease in mortality, and there was a slight increase in symptomatic intracranial hemorrhage. But overall, and this was like a meta-analysis of 1,876 patients. We took all of this data together, and I was very fortunate to essentially lead one of the guidelines documents looking at large core endovascular thrombectomy in some of these patients, like in patients with large ischemic strokes. The general recommendation was, the first recommendation was in patients with anterior circulation, large vessel occlusion strokes who present within 24 hours of last known well, thrombectomy is indicated, and we gave that a class 1 level A evidence. Endovascular thrombectomy in patients with large core stroke aged between 18 to 85 is beneficial. Again, we gave this 1A level of evidence. Patients more than 85, it may be beneficial. I don't think there is enough data at this point. It's completely reasonable to say that there is no data, and it has to be on a case-by-case basis. So this was a 1B. With regards to large core strokes and NIH stroke scale of 60 to 30, they benefit from endovascular thrombectomy, again, another level 1A. Patients with NIH stroke scale less than 6 and more than 30 may benefit from endovascular thrombectomy, and this was a 2A level of evidence. And patients with low baseline MRS, basically an MRS of 0 to 1, this one, again, we gave this a level of evidence 1A. With regards to the large core strokes and last known well, we limited this to 0 to 24 hours. And it's recommended that these patients who also meet criteria for on-label or guideline-directed use of IVTPA, irrespective of whether endovascular thrombectomy is being considered, we gave that level 1 evidence, but for that as well. So reading some of these trials, and I'm not sure, I apologize if I'm going over time, please let me know. I'm happy to stop at any point. I covered most of my high points. I was thinking, is it possible that these large core trials, they included patients up to 24 hours, is this effect driven by the patients who underwent endovascular thrombectomy within the first 6 hours? At least in my mind, I was like, let's do a subgroup analysis of this, a patient-level subgroup analysis looking at the first 6 hours versus beyond 6 hours. And this was because prior studies have shown that like a shorter time to treatment has been found to be directly associated with better outcome. So even if maybe you can argue that some of this hypodensity is all edema, and maybe they did not necessarily, this was not all infarcted tissue. My theory was the patients who presented earlier were going to do better, and they were the ones who were essentially driving the benefit from these large core trials. So we pulled the available data, and we looked at this, and what we found was functional outcome, again, favored endovascular thrombectomy over best medical management with an odds ratio of 1.4. However, shockingly, the pooled odds ratio did not favor endovascular thrombectomy when randomized less than 6 hours after last known well. And by contrast, if you presented more than 6 hours, in the more than 6 hour subgroup, endovascular thrombectomy treated patients showed better functional outcome than the best medical therapy, which basically to me indicated that perhaps we should be looking at these are patients who these were the rapid progressors, and the ones who had more time were able to present and still had some salvageable brain tissue beyond 6 hours. Those may be the patients who had some degree of collateral blood flow and continue to do well.
And Sabi,
Couple more minutes for us. Yes, sir.
All right, perfect. So ultimately, who benefits from these large core endovascular thrombectomy patients? I think we should say number needed to treat to achieve one additional functional independence and independence is close to 5, is approximately 5. The chance of, as far as the patients, I think the patients benefit from this. The chance of independent ambulation is 1 in 3, and the chance of independent independent survival is 1 in 5. Does society benefit from this? There's approximately large core strokes, in strokes in general, could be associated with almost 4.3 trillion US dollars and 18.3 of the GDP. But there is a massive potential cost saving for society with these by doing these large core strokes. However, at some point, my concern was, are we creating more survivors? And when you actually look at some of the last day slides, they decrease the MRS of 6, but also increase the MRS of 3 and 4, which many would argue an MRS of 3 is not necessarily a poor outcome. There was a trial that was published, I think it was called, I'm blanking out on its name. I can pull it up, and I'm blanking out on the name of the author, but I think it was called The Life Worth Living. They basically surveyed the survivors, and they said, the survivors basically said, the vast majority of them said, yes, they would go through this again. This was a life worth living for them. So in summary, we have 6 randomized controlled trials now showing a significant benefit of endovascular thrombectomy in large core infarctions, while the overall rates of good outcome are lower in magnitude than the small core trial. There's no doubt at this point, you have not 1, not 2, you have 6 trials that show that endovascular thrombectomy offers a significantly higher chance of good outcome when presenting within the first 24 hours. Large core strokes, thrombectomy is associated with independent ambulation 1 in 3 and independent survival 1 in 5 independent survival. There's also a mortality benefit across these trials. Hence, it's reasonable to offer mechanical thrombectomy. I'd like to take a second to thank my fellows and Dr. Dilip Yavagal for sharing some of these slides. And as I end, I'd love to welcome you all to join forces and join us with Mission Thrombectomy to improve life-saving stroke care in low middle income countries across the world. All right. And at this point, I rest my case. Happy to take questions, and we can discuss Dr. Asida's points from earlier on.
Perfect. That was so, let me say, impressive talk. I mean, you covered all of the spots about the large core stroke. But Sabi, do we have time to talk? Because
we are at 10:32 Abu Dhabi time, UAE time. So we are finished, but we'll still allow, about 5 to 10 minutes to answer questions.
So if you agree, let's go answer question. I mean, yes or no, because I'm sure that if we start to debate, it will take at least a week to talk on lots of. But you know what? I'm gonna repeat again. I'm not a neurologist, but what I learned from this business, there are certains in the stroke and there are uncertains in stroke. Like LVO, definite to treat. Maybe there's still you may not do. Small core, 100%, but the large core, question mark, right? So certains and uncertains. Large core to me is one of the uncertains. If we end up, do whatever you see, we will be happy. No limitation for the time window, no limitation for the localization, no, nothing at all. Do it at all. But that will be happy. And I'll be happy to do all stroke cases. If it be 100 per month, I would love to do it. But the problem here is when you do large core, you may have some bad results as well. And then when I look at those 6 random RCTs, let's say half of them is not real large core. in the technical part, imaging part, okay? DVI, it is reversal. You cannot say that it's large core. CBV or perfusion, technically, it's a relative technique. It's not a 100% true technique because you compare it to the other side. It's not, but the CT is yes. So if CT shows a large core, and we have patients like that, that's why RCT is showing benefit versus non-benefit. We don't know which one is going to have benefit. If CT 0 to 2 aspect shows a benefit, so there might be a problem with the aspect score as well. There should be an explanation for that. I mean, 0 aspect, so that means no brain, but we have still a benefit. I don't give an answer to that one.
So I mean, it's a great point. I mean, like I think Tudor Jovan and I were just discussing this just the other day. If we are just so ingrained in my mind, at least in my training, I'm going in to salvage the brain. And because this is what I see on the brain, like on the CAT scan, maybe this is not salvageable or this is salvageable. Perhaps it's time to look at this in a completely different way. Because we're doing thrombectomies now, at least based on these trials, they're doing thrombectomies on a patient with an aspect score of 0. And despite that, these patients are still doing there's still a benefit to this.
Okay, what is the
aspect of
explanation
0?
I got it.
Aspect of 0. Is there a component of edema that's essentially confusing us to some extent?
Oh yeah, what you're saying is that is the technical limitation. In fact, those cases are not aspect 0. Those cases are real aspect is something different. So aspect.
But even so, in last day you saw, I think the results panned out, right? Again, as to Fawaz's point, these are not Lazarus effects. They are not going to get up and walk. It's 13% compared to, I don't know, 5% or something. So the last day when it included almost 50% of 0 to 2, whether it is true aspects of 0 to 2, as in we can sit and debate all night, what is the true marker of, dead brain? And, you alluded to that already with imaging, what is the true surrogate of dead brain? I think we can debate about that, but I did think that the last day did show that the, outcomes was not robust, right? 13% versus 5, which it goes to support the fact that the lower you include, your outcomes are probably not going to be that great, but still showed benefit over medical management. So if I can ask Arcida and Fawaz, with all the information that you have now, tie it up for us. Is all this imaging for selection or prognostication? Please consider the MENA, where there are many, low and middle income countries. How do we select a patient? What do we counsel the patient or the family? Can you tie it up for us?
Okay, I will do my best. This is complicated. I will tell you my current practice, and I'll tell you what I think needs to happen. My current practice is I have 6 trials that tell me I can potentially take a patient with a large core stroke and offer them some benefit. I am very clear with the family. It's a discussion with the family. If they're under 85 and they're within 24 hours, I'm opening these blood vessels. At this point, I'm revascularizing these patients. But I'm having a very clear discussion with the families. You're not going to have a Lazarus effect. The likelihood that they're going to return to their baseline, an MRS of 0, is very low. But they may walk with a cane. They may need some help with their activities of daily living. If that is acceptable to you, then we will proceed. Is this something that we can extrapolate to low and middle income countries? I think that's a much harder question. These procedures are expensive. Care for these patients is expensive. Rehabilitation may not necessarily be available. As we're working on updating our white paper, the Mission Thrombectomy white paper, we're definitely going to include something on large core strokes in lay people, like a layman's terms, in lay language. But I'm not sure I would actually advocate for every patient to be taken in, just as an example, sub-Saharan Africa, for example, a relatively resource-limited area. I'm not sure we can actually say they should take every single patient for thrombectomy. It's very, very hard. That being said, it needs to be a discussion with the families. My practice today, if you're coming within 24 hours, regardless of the core, I'm probably taking the patient for a thrombectomy.
Arcida, can you comment on whether you keep it simple, whether you just want to do CT, CTA and you're happy, or do you need more information for prognostication versus selection? Like, would you exclude patients? Just unmute yourself.
We definitely have to exclude patients for large core, but those patients are mainly not excluded due to imaging. Those are mainly excluded due to age or pre-MRS. But I would like to quote what Tudor Jovin said before regarding the early treatment of large core patients. We know that chemotherapy, for example, is working for a very few number of patients, and we still are doing it, right, to help the patient to treat a cancer with a bad prognosis. And we know right now that thrombectomy for this patient is the only choice, is the only alternative that we have for treatment. The only concern that we have as Turkey or other countries is that if you are not able to take good care of this patient post-treatment, that the cost effective of you doing thrombectomy in large core is questionable. That's our only question mark regarding large core. To my opinion, we should treat patients with large core independent from the imaging, because right now we know that the only way to show viability of tissue is the PET imaging. We know that we can see salvageable tissue with PET, and we cannot do PET CT or PET MRI to stroke patients. So we know that perfusion, CT perfusion, MR perfusion, CT diffusion are very changeable. They do not show the perfect ischemia of the patient. So we know that maybe there are some cellular level which is still living, and we cannot be only based on aspect. But if we are treating these patients, there's a burden with this patient. Having a patient with MRS 4 and 5 in France is different with having a patient with MRS 4 and 5 in Turkey or in other countries. So the change between countries in post-management is something that we need to focus with this patient. But I believe that there is a group of patients, maybe not 24 hours, but maybe within 10 or 12 hours, which this patient should be treated despite what the country offers. But beyond those patients that have a very low aspect, those patients should be managed accordingly, because every country has its own demand and its own way of. Imagine you have 2 stroke patients in your stroke center. One is 50 years old, aspect 6. The other is 60 years old, aspect 2. And now you have evidence to do both. Which one will you choose? So I think the only problem that we have right now is that we don't have the best imaging modality for any kind of stroke, not only for large, even for low, for small core. Still, we don't know how viability we have in the tissue. So treating is better than not treating.
Are there any comments? Yes, I guess comments will take a week. You want to pick him.
Absolutely. Fawaz, any final comments?
I mean, I agree with everything that's being said. I think these are patients that we had pre-formed opinions about their outcomes, and I think there's still a lot we don't understand. I think in nonagenarians, patients above the age of 100, you probably should exercise some caution. I probably wouldn't be overly aggressive in revascularizing these patients. This is a more diseased brain, so potentially higher risk of reperfusion injury. If they're within 24 hours, their baseline MRS was 0 to 1. They were baseline intact. I think it's I always say, let them live, let them play.
No, come on, there are lots of different points that we don't know yet, but today, large core stroke to be treated, so yes. Who say no's? Yes. But large core LVO is similar with large core MEVO, we don't know. Large core early versus large core late, we may not know, we don't know. And then which one is very predictable to say that is large CT perfusion, MR perfusion, or whatever the diagnostic tool is. It's not clear yet, right? But
Great.
but take-home message, shall we treat large core patients for thrombectomy? I would say yes. And then I think that Fawaz will say yes. And everybody will say yes. Some can bleed. We don't know which one will be bleed. Is that correct?
No, completely agree.
That is
Completely
correct.
So
correct.
people have to understand that those cases meant to be treated with the thrombectomy. And then the rest is depends on the patient or the countries or whatever it is, hospitals, infrastructure, ability to do or not. But what we are doing today in our hospital, I mean, we are doing around 500 thrombectomy per year. We don't care about the large, late, early, whatever it is, MEVO, LVO. We do all of them.
Yeah. Okay, at
And in
least
terms of just one quick point, in terms of fast progressors, they will be fast in a way, so you have to be faster. Because most of the people that treat large core are more afraid about the fast progressor patient that come as Faz mentioned in the beautiful presentation. He said that they're the patients within 0 to 6 hours, they are fast progressor. But we have to know that this patient, despite whatever we do, they will be fast progressor. So we have to focus on patients that can have a benefit. Fast progressor, it's out of all the rules of mechanic thrombectomy or randomized control. There is a special group that whichever study you do, they will not benefit. We know that. So we have to aim for patients that benefit, the majority of the patients that benefit.
But RCTs are different subject because, I mean, like the TPA, non-TPA trials, I like it at all. TPA, yeah, give TPA. Most of the RCTs exclude, let's say, tandems, but they're tandems with the high NIH, and then the result is generalized. If there's high NIH patient, you give TPA, right?
but at least it is reassuring.
Does not include all high NIH patient.
Mhm.
The design of the RCT is something different, and the level of the evidence, the term level of the evidence is another topic to subject to talk. I mean, there are lots of gray points as well. But today, what we have in our hand, we don't know how it happens, but even with the 0 to 2 aspect, some patient has benefit. Is that correct?
Yeah, I think you summed it up well. Complex topics, large core for sure, many unanswered questions. But I think, panel, we will wrap it up. It's 10:45 over here. I'm sure we'll have a lot more questions if we keep going on. But again, audience, thank you very much for staying up late. Thank you to all the speakers, Dr. Fawaz, Dr. Arsida, Dr. Qureshi, and thank you, Dr. Sardar, for co-moderating. Thank you, Dr. Suhail Al-Rukn, the president of MENASO, for giving this opportunity. And I think you will get information about the CME. A few of questions unanswered, but feel free to reach out to me. I will get back to you. Once again, thank you, panel, and thank you, audience. Thank you very, very much, and have a good evening.
Have a good night.
Thank you. Good night.
Take
See
care.
you. Bye. Bye.
Bye-bye.
Bye-bye.